Hello, my name is Lauren Fleer, and this is Catherine Fisher, Amber Ferrand, and Jessica Garcia. We are here today as a consultant group to provide a comprehensive plan which encompasses both the improved care of patients who have experienced stroke, as well as the prevention of future incidences here in the South Tree Health Network, or STHN. Imagine visiting with your grandmother when suddenly her speech becomes slurred. Then you begin to notice that her mouth is drooping on one side and she can no longer move her right arm. How are you going to prevent your grandmother from becoming yet another stroke statistic? How did this even happen to her? Throughout this presentation, we are going to provide a background and root cause analysis on the current issues affecting STHN. Next, we will detail our recommended interventions, highlighting our Think Fast campaign, which promotes the recognition of stroke symptoms. And finally, we will move into our financial analysis, which includes cost savings projections. Annually, 800,000 people in the United States experience a stroke. Furthermore, stroke is the leading cause of serious long-term disability. When looking at the screen, you can see that Kentucky and the surrounding areas have a higher rate of stroke than most other areas nationally. In fact, in Kentucky, stroke is the 4th leading cause of death, whereas nationally it comes in as the 5th leading cause. We would like to suggest that this is due to a higher incidence of the risk factors included on the chart. Specifically, I would like to highlight smoking, obesity, and heart disease. Our goal is to increase the fulfillment of performance outcome measures by 35% within 5 years in order to improve the patient health here at STHN. Many of our performance outcome measures have been derived directly from the Kentucky Stroke Encounter Quality Improvement Project. As you can see on this graphic, we would like to specifically focus in on patient health literacy, stroke education specifically, with dysphagia screenings, administration, and the administration of TPA. Additionally, we plan to implement an inter-network EHR, or electronic health record system. Now to my colleague Catherine to discuss the root cause analysis.
Thank you, Lauren. Now let's meet a recent patient of ours, Lynette Tate. Lynette is a 53-year-old Caucasian female from Ginkgo Grove, Kentucky. She suffered a stroke in June of last year. Before the Affordable Care Act, Lynette either had high insurance premiums or no insurance coverage because it was too expensive. Because of this, she didn't go to the doctor regularly, so she didn't know that she had high blood pressure and diabetes, both of which increase your risk for having a stroke. In 2013, when Lynette purchased a lower-cost insurance, she didn't take advantage of the no additional cost preventative screenings because she wanted to wait until she got sick to find a doctor. Lynette's low health literacy also contributed to the situation. Sadly, Lynette's story is similar to many of our patients where a low income, unhealthy lifestyle, low health literacy, and low healthcare access only worsen the Kentucky stroke problem. Only 10% of Kentucky's emergency responders have been trained using the National Stroke Association's Stroke Rapid Response curriculum. Increasing the number of EMTs with this training should decrease door-to-needle times, allowing for quicker TPA administration and increasing functional outcomes after a stroke. We currently don't have an interdisciplinary team in place, leading to miscommunication between our providers within our own network. This lack of communication is exacerbated when trying to manage patients who have had a stroke with multiple medical conditions. Also, as providers, we have a problem of not educating the patient properly. We at STHN cannot expect to empower patients to take charge of their own health care if they don't understand their own health conditions. The first directive of the triple aim is to improve the patient experience, but we can't do that if we can't transfer information within our own network. It is unacceptable that not all of our member organizations use the same EHR platform. An integrated EHR system is crucial to improving effective communication within our own network. The second part of the triple aim is to improve the population health. STHN already offers free hospital-based community education programs, advertising about stroke, and a free screening program. But these initiatives are not all coordinated in their delivery. We need to improve our education to the public about the warning signs of stroke and to call 911 as soon as possible so that EMTs can transport them to the nearest stroke center. Because with stroke, time is critically important, and the sooner you can get a patient to a stroke center, the sooner we can get them treatment. Additionally, our current situation has been leading to patient abandonment, which can lead to lawsuits and further unnecessary expenditures. While we were considering our recommendations, we wanted to be sure that we were adhering not only to our triple aim goals, but also to national guidelines, while striving to maintain the highest level of sustainability. 2/3 of the cost to treat a patient who has had a stroke is from rehabilitation. This is a situation where every minute counts because you lose 2 million brain cells a minute during a stroke, and that can be the difference between surviving or not surviving a stroke, or being fully disabled or not. TPA is a clot-busting drug that reduces long-term disability when administered within 4 hours of stroke onset. So we will be using the AHA Target Stroke Phase 2 initiative and aiming for door-to-needle times of 60 minutes or less. So once dispatched, the EMS is going to send out a single alert to the pre-planned hospital to prepare the stroke team. The team will then reserve and prepare the CT scanner while the patient is en route and begin to premix a TPA. We will be using the Get With The Guidelines patient management tool in order to keep track of our TPA administration rates, door-to-needle times, and other performance measures so that we can continuously identify areas for improvement during this initiative. Also, we are very excited to announce that we're going to be acquiring a mobile stroke unit, or MSU, that will be operational in 3 years in the Lexington area. The MSU will have a CT scanner and video technology that will allow for our vascular neurologist to visually assess the patient on site. This is going to be like bringing an ER to the patient's house, so the sooner we can get this out on the street, the sooner we will be able to see benefit for the community at large. The future MSU team will have a paramedic, EMT, and a nurse who will perform patient care, get the CT scan, and interact with the remote neurologist via telemedicine. The patients who are going to be treated with the MSU will have better outcomes because of quicker treatment and therefore have fewer long-term rehabilitation needs. Because of this, we are hoping to be able to build up enough long-term savings to be able to acquire more MSUs in the future. As previously mentioned, only 10% of Kentucky's emergency responders are considered stroke ready. So we are going to be using the Stroke Rapid Response and EMS for Stroke curriculums in order to train on the warning signs of stroke, how to use the pre-screening tools, the administration of fast MAG cardiomeds, the MSU communication tools, and these responders' invaluable role in preventing long-term complications for these patients. And now to Amber to continue with our recommendations.
Thank you, Catherine. Our evidence-based indicators will be of the highest value of safety, effectiveness, and patient satisfaction. In line with JCO Stroke 2015 stroke standards, we recommend the following addition of a stroke coordinator, pre-discharge quality surveys for instant unbiased feedback, secondary interventions such as counseling for depression screening and smoking cessations if needed, therapy for motor recovery, our new palliative care planning model, interdisciplinary discharge team, and of course, including the family as part of our interprofessional team. We ask you to please see our appendix for our full stroke-specific indicators. We know that patient-centered care is going to take a team approach, making sure that we understand the patient fully inside, family and friends, and of course their home and natural environment such as workplace. The gray circle in the middle indicates the need for professionals to work seamlessly and within a circle of trust that we're all working for the same goal, as patient-centered care is too great for one individual. And communication, of course, is always the key. Typically, in a Sentinel event, communication is the #1 reason. With all the different forms of communication out there now, it's important to identify a single communication tool. For example, ISBAR and team steps between our professionals, AIDIT for patient and professional interaction, and of course integrating our EHR for seamless continuum of care. We also recommend a more tactile form of communication in the form of an alert bracelet. As we talked about previously, our dysphagia outcome needs to be improved. Our plan deems all patients in PO until our trained nursing staff is able to perform a bedside dysphagia screen. If there's cause for concern, patient and family will be informed. It'll be immediately entered into the new EHR system. Doctors and speech therapy will be alerted. Once speech therapy is able to perform their evaluation with instantaneous results, as opposed to Lynette, who unfortunately got 24-hour results, an orange stripe bracelet as shown above will be donned to let our professionals know that this patient has special dietary concerns and has been seen by speech therapy. This will also aid in our handovers to other facilities. We've already been in contact with the Vice President of Health Policy, Ms. Cobb, over at the Kentucky Hospital Administration. She has already approved our bracelets and given us the 1-year initiative protocols. Another disturbing fact that we found in our network is patient abandonment. We know that with our improved EHR system, communication tools, and interprofessional approach, we can improve our patient education, we can improve our medical referrals, We can also improve our facilities as far as alerting for follow-ups and our interdisciplinary approach for discharge planning, as mandated by the Department of Health and Human Services, which we are not following currently. We also need to make sure that our discharge protocols are updated as in line with our new indicators, and we need to revisit our rural medical personnel's contracts. We also advise you can look into the appendix and see our new interprofessional approach and dysphagia screens. Now let's change gears for a little bit and talk about prevention. Our partners at UCLA Stroke and Research Center have deemed prevention is still the #1 way to decrease the burden of stroke. As you can see by the graphic, 92% of all strokes could have been prevented. This is an immense number that we need to target with our new health literacy campaign headed by our health abstractor. Our plan starts within the schools. As part of our new medical model for our students, they will be required to perform volunteer hours for pre-made activities with our school students and faculty. We also need to be more involved in advocacy, not only locally, but on the national stage. For example, promotion of House Bill 193, smoking ban in all public places. We need to make sure we repeal Medicare therapy caps and increase reimbursements for our rural medical personnel. The health abstractor will also be in charge of our community outreach, increasing our mobile screens to a more dense population at local pharmacies, schools, and shopping centers. They'll also be in charge of gathering our network for our new corporate wellness campaign. We're really excited to roll out this campaign as it's going to be a new dynamic to workplace benefits for the Kentucky employees. With our partnerships through National WellSource, LA Fitness, and Planet Fitness, we will be able to provide employees every opportunity to obtain the 3 main health outcomes set forth by the Affordable Care Act for our employees to obtain up to 50% off premiums each year. This could be hundreds of savings for our employees, benefits, and of course, increasing revenue for our network. Currently, 40% of the population still do not recognize signs of stroke, and fewer than half of all 911 calls come in within an hour of onset of symptoms. With our new community outreach, we want to make sure that we update our website, mailers, billboards, social media, and apps with a new Think Fast branding campaign. We need to engage the public to think fast, call 911, and strike back against stroke. Now to Jessica with our financial implications.
Thank you, Amber. STHN is planning to enroll 100,000 Kentucky residents in the next 5 years. And we know that the stroke hospitalization rate is 27.7 per 10,000 people. This means that within this period of time, we're looking at a minimum of 277 cases for our network. We also know that the average cost of treating a patient who has had a stroke is around $16,000. In order to eradicate the issues mentioned earlier, we will invest in coordination of care, training for all of our staff, our mobile stroke unit, and of course our EHR system. Initially, we will require around $800,000 to carry on with our initiatives. We believe this investment is reasonable since the potential savings and the benefits for this community are much greater. Changing without value is unacceptable. This is why CMS has pushed towards new value-driven payment models. The blue dots indicate organizations that are already trying a model in Kentucky. We believe that the best model for us will be the bundle payment arrangement, as it supports cross-continuum care and it eases management services for high-cost specific populations. Also, unlike the rest of the models, there is no disincentive to participate in service reductions. We also hope to see positive patient reaction, as traditionally, the link between hospital care and post-acute care has tended to be weak, making it difficult for patients to navigate a complex healthcare environment, as it is Lynette's case. If everyone watches the care process, better quality and lower costs can be achieved. Bundle payments need to consider direct contract results, as these can be the drivers for reduced utilization and improved clinical care and operations. CMS has offered grants up to $4.5 million for organizations that have tried these models before. We believe that opportunities like this, as well as PQRS reporting, are potential means of further investing in our efforts. Also, since STHN has a vision to convert into an ACO, a bundle payment arrangement will ease the transition. If no action is taken, STHN will incur an almost $5 million of stroke-related costs within the next 5 years. However, by transitioning into the bundle payment approach, we can gradually see cost reductions. Organizations that have made this transition before have seen cost reductions ranging from 2% to 23% per case. We know that transitioning to value-based payments has its financial risks. This is why we will need to build capabilities to ensure that care redesign doesn't outpace reimbursement changes. In order to maintain sustainability, we will need to identify savings opportunities through productivity management and our stroke service line consolidation. With our high-performing team, we can drive out waste and unnecessary variation. Some core savings opportunities are having a single provider in pharmacy and lab, supply chain management, the compensation structure, and some other ideas from management and staff. We believe that with this and with our action plan, we can reduce unnecessary variation and also increase our contribution margin. And now Lauren will conclude the presentation.
Thank you, Jessica. Because our plan has many different facets, implementation will be gradual. Standardized dysphagia screenings and patient satisfaction surveys will be initiated during year 1. Faster TPA administration will be accomplished during years 1 and 2, while the mobile stroke unit will be up and functioning by the end of year 3. The integration of EHR systems between the different institutions in our network will occur over years 2 through 4, and our health literacy programs will be established by the end of year 5. All clinical quality indicators, beyond those emphasized here, will continually be assessed. Additionally, because the bundled payment option is a 3-year initiative, the ability to successfully transition to an ACO will be assessed at the beginning of year 4 through year 5. Prioritization of these initiatives has been done in such a way that we can feasibly complete all of them in the given time frame and with the available funding. With this plan, a cost reduction of up to 23% per stroke incidence can be seen. Additionally, we could potentially receive up to $4.5 million in grants from CMS. All targets of the triple aim have been addressed with this plan as well. The patient experience will be improved by offering coordinated and guideline-directed care. Population health will be improved by offering more widespread stroke prevention education as well as health screening opportunities. And lastly, cost reductions will be seen by offering the bundled payment option as well as decreasing the amount of stroke incidences overall. Every 40 seconds, someone in the United States is experiencing the effects of stroke. This means during our 20-minute presentation here with you today, 30 people have had a stroke. This is why it is imperative for us here at STHN to think fast in order to provide improved patient care within our network. Thank you.
Yes.
Questions? So I may have missed it, but you're talking about FAST, but it's got periods. So does it stand for something?
Go ahead.
Yes, so the Think Fast program is talking about fast meaning face, arm, speech, and then time to call 911.
Okay, got it. Good presentation. I have lots of questions, but I don't know where to begin. So you made a couple of references in the class to productivity management and compensation structure. And I assume that you were referring to physicians, but I wasn't sure. But my question would be, in a value-based system that you're proposing to go, how do you deal with physician compensation? And what are you going to pay, or how are you going to base payment on what type of measurement?
So initially we are starting out with the bundled payment option, which we do realize is a volume-based plan because of the high incidence of stroke that we are experiencing in our network currently. We are implementing the prevention strategies to work towards a value-based care plan, the ACO, like you mentioned. And because stroke is not necessarily right now one of the healthcare issues that is fined by CMS for readmissions, we are going to stress to our physicians the importance of it is the 4th leading cause of death in Kentucky, so as a result, it will, and 5th in the United States overall. So the likelihood of it becoming one of these conditions is very high. So we need to definitely make sure that they understand that, one, while it's not an implication right now for them, it will be in the future. So it is definitely in the benefit of them and our network to work towards decreasing readmissions and admissions here in Kentucky.
So you would use that as one of the value-based measurements. What did you mean by productivity management?
Well, we have the vision to convert into an ACO. So similar to what they do, we want to link all of our outcome measures and quality measures with our productivity management and have the compensation structure somewhat related to that.
So, but productivity, you mean efficiency?
Yes.
Okay.
Thank you. So I have a number of questions. You referenced the electronic health record as being one of the key interventions. How are you going to pay for that? How would we even begin to think about that?
Well, we are assuming that they have all the hard drive that they need. So the way we looked into,
That's a big assumption. All the different parts of the organization, outpatient and rehab?
Well, we've looked at this upgrade that does integration within all of these different organizations. So we're going to know what service has been done in one organization and the other one, so that services are not duplicated.
Right, and we really definitely want to look before leaping into a new program like this.
Yes. Yeah.
So as you may have seen on the timeline, we're going to start at year 2. We want to make sure that we talk with our providers first, get their positives, get their negatives with the system that we already have and the hardware that we already have within our system, so that when we do start to integrate between facilities, we'll know exactly, like she said, there won't be duplicates, we won't have to be doing things over again, and we'll already have a plan in place so that it can be more efficient when we do roll it out.
Yeah,
Okay.
we will focus on consensus within everyone in the network.
Okay. So more on connecting disparate systems than bringing in a new
Correct.
Right.
system.
Yeah, and we're
Okay.
going to use that SAS program for the integration, since our hardware is good hardware. We just need to make sure that they're all talking
Okay.
to each other.
I was very interested and pleased that you brought out depression screening and family engagement as part of the upstream concerns for looking at stroke. Depression screening, where and how much?
Well, we know right now that in our hospital system, just catty corner to us, there is counseling services there. So we can incorporate them, but also with our therapies, they are trained to do screens for depression. So they can be touched more than once, as far as like mini mental exams and different types of outcome measures that we use. So they will be able to, therapy and rehab will be able to do it, and the counselors can come over and work the depression screen, and it's actually part of our outcome quality indicators as well.
Should we be thinking of embedding this in primary care?
I think
that would be a good option. Well, I guess where we started trying to prioritize things is what can we feasibly do and actually see results from. So I definitely agree, and as I think most of us do, that is a very important thing, because depression does have a huge effect on quality of life.
Right, and not just for the patient, but the family as well.
Yes.
So the risk of being annoying, I was interested to see that you prioritized patient satisfaction in, I think it was year 2 or year 1, and didn't get to life-saving interventions until year 3. Does it matter if you're satisfied if you don't make it?
Correct. Okay, so that's something. That's something we definitely struggled with, is prioritization, just because of the cost, like we talked about with the EHR integration versus the cost of dysphagia screenings and patient satisfaction surveys. So our thought process is we already have the staff to implement the screenings, because we already have the nurses. We just need to pull them in for a training day and explain, from now on, this is the protocol we'll be following for these types of screenings, as well as the patient satisfaction surveys. We would, of course, like to see some of the other things, if possible, be moved up to earlier time frame, earlier years, but because of the ease of implementing those two specific protocols, those were listed first, not necessarily because we think we'll see the biggest, maybe direct patient improvements, but because we know with the staff we have and the funds we have initially starting out, we can successfully complete those.
Right, and with our... I'm sorry.
Go ahead.
With our prevention measures, we know we're going to have to hire the health abstractor. They're going to have to set up the different networks throughout the community, set up the new curriculum. So it's going to take a longer process to set everything in place that we want to do first before we can implement.
And then additionally, we already have, we're already getting the free education programs and, the screening programs and the advertising, so we're going to use that same budget. So we weren't going to, need extra money to be able to start that.
Or you could redirect money
And,
Right.
well,
Yes,
we
of
would
to life-saving
Correct.
interventions as opposed,
as well as, doing a better job of educating the public.
And last question.
No, you're fine. It's fine.
You recommended an alert bracelet, and I know there's a lot of conflicting evidence about the utility of an alert bracelet maybe creating more risk than helping identify risk. Did you run across?
Well, when we spoke,
How should we think about
Right.
that?
Well, when we spoke with the folks over at the Kentucky Hospital Administration, they kind of walked us through what their thoughts on the process were, and as long as we were not kind of impinging on the bracelets that they already have in place as the state measure, that we were more than welcome to, because they feel that it is a great communication tool between not just providers, but within the facility. So again, if we were trying to translate to an ACO and make sure that everybody's working together, we'll know that the people within our system will recognize the bracelet and be drawn to it. But she said as long as we aren't impinging on the ones they already have, that we're free to implement the bracelets.
I think that this is one of the issues that where training will be crucial, so that everyone knows what this is about and we're all at the same page, so that it actually works for us.
And then we also said that we were going to be continuously, identifying areas for improvement. So we'll be sure to monitor, is this actually making a difference? And if not, then we will have to, reevaluate and try to come up with a different plan.
Thank you.
Thank you.
Thank you.
Okay.
Sorry.
I just got a couple quick questions. A little bit more information about the mobile stroke unit.
Yes, sir.
What is the range, what's the radius of the range of coverage of the mobile stroke unit? And do you have any information yet about quality and safety of outcomes in those patients that are treated in the mobile stroke unit? And will a mobile stroke unit be applicable in our system region, or just in the immediate Lexington, Kentucky area?
Okay. Let me just make sure I remember everything. So the radius of the mobile stroke units that are currently in place is about 15 miles. Of course, we would have to do some studies to make sure that how far what's the distance of a mobile stroke unit can go within a certain amount of time period, because depending on traffic at certain times of the day. Then also, sorry, I'm just trying to remember all the questions.
With our mobile stroke unit, at first we're going to be running 6 days a week, mainly during a 12-hour time frame, just so we can make sure that our personnel is kind of ready to make sure on call and to go out. Through the research that we've done with our partnerships in Germany and in Houston, where the two heads that have already started this mobile stroke unit, they say that they've been able to treat within less than 60 minutes about 30% of the patient population, as opposed to when they call in, they're treating about 4% of the population that's had a stroke. And then our colleagues in Houston, when they reassess their Get With The Guidelines Phase 1, they're actually only treating less than 1% of the population with TPA within the hour time frame, but they've found similar results as they're about 30% success rate as of right now.
And then additionally, before, with using the Target Stroke Phase 2 initiative, about the average time for TPA administration is about 70 minutes. With mobile stroke unit, they've found, at least in Houston, that they're bringing it down to about 40 minutes. So that's a huge amount of time, with especially losing, 2 million brain cells a minute. That's a lot.
Can I ask one more question?
We're actually over.
Oh, okay.
I'm sorry.
Thank you.
But you can
take it as feedback.
Well,
Yes,
Thank you.
so have you done any probabilistic risk assessment relative from a population health standpoint? If we implement your recommendations, if we fully implement what you're talking about, what's it going to do to, how would it reduce the stroke rate in our population? And of those that have strokes, how might it impact morbidity and mortality?
Sorry.
Well, we think with our outcome, like updating the outcome measures to more quality-based, we'll be able to track that a little bit better because every professional that's coming in is going to be in charge of those specific outcomes. So the population that has already had a stroke will be able to kind of monitor and make sure that they get the education as well as their family. And then with our prevention measures, we're trying to target the students, but also have them bring the message home to their parents and family and kind of spread the word that way, especially in a rural population where more word of mouth is sort of required. So we're hoping that it can kind of affect both adults, children, everybody across the lifespan.
As far as an actual percentage, we don't have a hard number or, no way of knowing that for sure at this time.
And then additionally, too, like with the quicker TPA administration that we should be getting with all these implementations, there should be reduced, like, 2/3 of the cost of stroke is from rehabilitation. So that's about, and $16,000 is the average cost, so it's $10,000 saving per patient. Yes. So hopefully we'll be able to get something.
So, I think you purposely did it, but it was what I thought was a very good approach. Is you started out with emotion, you captured that, and then you went to facts, and then you finished up with emotion. It was very powerful from that standpoint, especially if we're a non-medically related board. You did a really good job of educating me about things, and I thought that was really good. Having an aim like that was impressive, to really nail what that was. You're Catherine?
Yes.
So when she said it was non-acceptable, I sort of got my attention from that standpoint. And that's sometimes one of the things in giving a presentation is what I call pace. And pace means it's not the same all the time, talking the same way. It's going up and down. And the one thing is in your presentation, the pace tended to be very level. Our discussion here, much more passionate. So, and the other thing is the use of your arms to open yourself up when you're talking so that you're engaging the group as you speak. You educated me. I don't know, I might have missed it, but I don't know that you talked about fast, what it meant. I don't and so that was the one thing that I spent about.
That's true.
Keep going back. Fast, did they say it or did I miss it? It bothered me when you switched places. I don't know that that's a good technique to move to the front of the line. It almost makes it seem that one person's more important than the other.
Okay.
And then pay attention to the person who's talking by looking at them. I really like that you didn't talk off the slides. The slides didn't distract me. They were complimentary. They were a picture. Then I could come back and look at you. The only comment was there was one slide where you had something down there about levels of intimacy. That distracted me because I'm trying to read it, can't read it. It was not needed on the slide. I know the points you were trying to make, but it was a little thing in one of the slides that probably didn't need. Otherwise, good presentation. I tell all the groups, you got to remember to breathe. Your brain only functions well without breathing for 40 seconds. If you don't breathe, all of a sudden, things.
Thank you.
Thank you.
I would echo the comments. It was very well organized and presented, and I thought the making the startup with making it personal was great. And you ended it the same way. Again, the emotion, the impact of that made this a very important topic. I like that you contexted Kentucky to the United States, so we see the expanse of the problem, and that was helpful, I think. And then went into the drivers of why Kentucky is at a variance to the rest of the United States. That was very well done. Provider characteristics was a very interesting piece that you put in there, particularly with the EMS system and the team. And that provided the platform for the other recommendations that you made later, and it really helped. And on a personal note, I've spent the last 6 years trying to get people to talk about handovers instead of handoffs. And so you used handover, and it was just great to hear that there's a reciprocal accepting and giving of information rather than throwing someone over the transom. Again, you included advocacy, outreach, public awareness, and we're very up to date with social media. And I had the same response to the quote, change without value is unacceptable. That made a very clear point to a board about what we should be looking at. So thank you.
Thank you.
Thank you.
Very nice presentation. Sorry about my voice. Getting over a respiratory thing. I hope I'm getting over it. I think.
Hopefully it's no longer
I may have to sign off. The two real strengths of this presentation were I really liked the focus and the detail about the urgency of time criticality of stroke intervention. That's just the more clinical experience we have in this country and around the world with this, the more we realize how important this is. Door to needle time and even pre-door time is just critically important. The second thing that I really liked, I thought was very strong in your presentation, was the detail about the community outreach program and the educational program. The only thing, there was one thing that was a little bit distracting to me, and it was one of the first few paragraphs or so about the fact that you're going to focus on obesity and smoking cessation, and I didn't get the flow of what that was all about, because clearly the next problems were hypercholesterolemia, hypertension, and diabetes. So that was distracting, and I never did figure out exactly where you were going with that. The other thing, and this is a really peripheral aside, but I think so much of the issues in this case and in this region are cultural, huge cultural issues. And to have perhaps addressed or talked about the community outreach program, how that might help change patients' perceptions of distrust for the healthcare system, might have been interesting to explore. But realize you're in tight time constraints. So very nice job. Thank you.
Thank you.
Just the other comment is that your dress was very professional, not distracting, and you looked like a team.
Thank you.
Thank you.
Good job.
Thank you.